Dale, dale, hasta que llegue. Apúrate. Are we ready? ¿Ya está todo listo?
Should be.
Escucha, ahí viene, ahí viene, ahí viene. Ahí viene.
Oh no. Facelifts?
Are we ready?
Facelifts?
Don't you know what we're gonna talk about?
Boobs?
Yes.
Oh, that's
Of course. Well, hello there, empowered ladies. We're back at Dr. Soler Bayo's office, and today we will be discussing breast surgery. We will be taking it to the drawing board where Dr. Soler will discuss techniques, sizing, augmentation, etc. Thank you, Dr. Soler, for being such a supporter of Mari.Trilogy and for your time today.
Thank you, Mary. It's lovely to be here again. I think it's really wonderful what you're doing, letting everyone know about all sorts of health issues, wellness, and plastic surgery. So today we'll talk a lot about breast surgery, and I know you have some questions for me that people have talked about, and go ahead. Let's do this.
Well, we have a lot of questions from our previous podcasts, and it's a combination of a lot of things, but we're going to narrow it down today to breast surgery. And we're going to begin with your trademarked scarless surgery augmentation. We've gotten a lot of questions on that. And based on the response, we're going to start with the first question, which is, what exactly is scarless breast augmentation and where are the incisions typically placed?
So the term scarless is because you cannot see the scar. Anytime we do surgery, there is a scar involved. So for me, the scarless breast augmentation was learning a technique called the transaxillary breast augmentation, which is placing the implant through the armpit and a small incision in the armpit, in the crease of the armpit. When you have that, you really will not see a scar after about a year because it sits in the crease of the armpit. Now, traditionally, as we can see in this picture, there are generally two accepted ways and the transaxillary. So 3 ways where we put implants in. Most doctors put in the implant through what's called the inframammary fold, as you can see here. And that is the most common way everyone does it. A second way to do it is through the nipple. Essentially, it's called a periareolar incision, which is a very good operation. It does carry a slightly higher risk of capsular contracture, but most of the doctors in the country today are doing the inframammary approach because it is easy to teach, it is easy to learn, and it's a great technique. The only thing that I don't like about it is the scar. And you can, if you scar really well, sometimes it's relatively imperceptible, but if you do scar heavy, you'll have 2 incisions under your breasts. And here in Miami, everyone wears tiny, tiny bikinis.
Yes,
And if you raise your arms, sometimes you will see these scars. So for me, putting the scar in the armpit, number one, it heals really, really well. Even if you scar poorly, the armpit heals really well. And as you can see in this picture, after about a year, it's gone. You literally can't see it. So I love to do that. The second thing that I do is I can place 2 types of implants through the armpit. I am one of the few doctors in the country, and then we're over 5,000 and change board certified plastic surgeons, and less than 2% do transaxillary surgery. And probably less than 1% do it with a camera, with an endoscope, which is the way you can perform the surgery in an identical fashion. So you're doing the same surgery, just through a different approach.
Wow. Okay. And you use that scope, correct?
The scope, for me, is necessary because it gives you the control. It gives you the visualization, and essentially you're doing the same operation, just with an endoscope.
Oh, well, thank you for that. That leads me to the next question. Are there any limitations with implant size or type when choosing the scarless?
Well,
technique?
I've always been a bit of a conservative guy when it comes to size. I've been doing this for a long time, and I've always counseled women not to go too big. And now, but that's one of my biggest challenges is everyone says, go bigger because you'll regret it later. I've done this for so long that I've seen women get big implants and then regret it 10, 15 years later I've been doing this long enough that I've seen the women that have gotten the large implants, and then they get heavy, they stretch out, and now they're dealing with implants that they really don't want.
Wow. Yeah, I can imagine. It is, if you get heavier, you look even heavier.
So to answer more of that question, the sizing is really based on the base diameter. And you can watch this little short video that I made, if you'd like, regarding how I choose the sizes and how I use that sizing, similar to when you try on your shirt or you try on your shoes. There's something that's going to be too big, too small, and something that's going to be just right. And to make it look natural, you need to size the implant properly to each patient.
Yeah. I would imagine patients' dimensions and,
So the diameter, the base diameter is everything. So the width of an implant, right? So you measure the width of the patient's chest, the breast itself, and the implant should sit there perfectly. It shouldn't be bigger than that space and it shouldn't be smaller than that space.
Oh.
So if you can have it smaller and then you'll have a very modest augmentation. But if you want something that looks really, really natural, you definitely don't want to go bigger.
How does recovery from scarless augmentation compared to the traditional augmentation?
So like I said, the operation's the same. What hurts, and I perform what's called a dual plane augmentation. So a dual plane, and you can look at this little diagram, is where the implant sits partly under the muscle and partly under the glandular tissue. And both or all breast operations that I perform, whether I do it through the nipple, inframammary fold, or the armpit, they all are dual plane operations. I think it's a better operation. I think it gives the most natural result. So dual plane means that it's partially under the muscle and partially under the glandular tissue. And that's a really important thing because it's been the most successful, and we've done it like this for over 30 years, this dual plane operation. And that's the one that I believe, Kylie Jenner, she talked about her breast augmentation, and guess what? It was a dual plane operation. So it's the way to go. For me, the difference in recovery, not really that much. Whether I do it through, usually I like the peri-areolar approach if I'm not doing the transaxillary, because again, we live in Miami and girls just wear tiny bathing suits and you don't want to have those scars shown.
Right.
The recovery itself, I do what's called rapid recovery or flash recovery. I use very gentle techniques when I do the operation. So people tell me the next day, I don't feel so bad. The other thing I like to do is ice therapy. Because technically we're traumatizing the muscle when we're going under the muscle. So if you pull the muscle, what do? You ice it. So if you do ice therapy the first 48 hours, sometimes they take Tylenol and that's good enough.
But what is the average? Is it a month, 3 months?
No, normally you're driving in 5 days.
Oh, wow.
And usually most implants sit high when you first put them in. If there's normal anatomy, just say a normal breast, and they sit kind of high, and there's a period what we call settling. And depending on the tissue, that settling can take up to 2 months to get to where it's going to go. If it's someone that hasn't had babies, has just tight young tissue, but someone that has had babies and it's been stretched out, that could that could happen faster because then the tissue's not so tight.
Wow.
So it settles quicker. And then if it's really weak, then you can get into situations where we're now using what's called an internal bra, and we're using a mesh to actually help hold the implant in place.
Oh, wow. That's super interesting. Can you tell us a little bit more about that?
So the internal bra has been around for a bit. It's essentially using an absorbable mesh. So imagine a mesh, a little web that's sutured to the chest wall, and it cradles the implant. So it allows for more support of the implant, and that way the implant will not settle too much. Because if imagine that what's holding it is that skin and some weak breast tissue, that implant might bottom out. It might settle too much. So by creating this temporary support, and that mesh gets absorbed into the body. So, but it creates a little bit of scar tissue, which will support and cradle that implant in position way better than if you didn't.
Wow.
So that's the internal bra.
That's very educational. Thank you so much for that. Let's jump into the traditional breast lift. Okay. So why is breast lift considered a separate surgery from augmentation?
So the most important thing about a breast lift, and I like to explain this one. The reason why we do breast lifts is really because of nipple position. So the way plastic surgeons describe droopiness of the breast is by understanding how the nipple is positioned when referenced to the inframammary fold. So the inframammary fold is where your breast meets your chest. You know how they talk about the pencil test? That's the fold.
Oh, yes.
That's the fold we're talking about. So the nipple, if the nipple's above that fold, you're in pretty good shape. If the nipple is at the fold and below, you start to consider that even if you put an implant in, that nipple will be too low after the operation. So what the lift actually does is repositions the nipple so it actually looks attractive. And you can do that with an implant or without an implant. And so there's a pattern that is used for both breast lifts, and I know we're going to talk about breast reductions, but the pattern is really the same. And
Can you show us a little story for
let's
that?
go to the drawing board.
Let's go to the drawing board.
So let's talk about what we just discussed. If the breast, say it's looking like a large breast and the nipple is low, it looks droopy. And if it's really low, the nipple's way down here, it's even more droopy. So the fold that we talk about, it's called the IMF, inframammary fold. So if the nipple was in this position, it would be ideal. So what do? We create a pattern that looks like that.
Oh.
And so plastic surgeons, we didn't know how to make breasts. So what did we do? We studied bra makers, and we took the cloth pattern of making a bra, which is essentially something like this, and we just added the opening for the areola. And so now what we do is we take the areola that's low and we move it into the new position. And in this pattern, we remove the skin from all of this area. So what we end up with is a much nicer looking breast.
Of course.
And this will join that and create that vertical scar that actually moves the nipple up. And then this whole bottom part really shortens the breast and makes it into a much more youthful breast.
So, Dr. Soler, what are the common incision patterns for a traditional breast lift, and how visible are the scars over time?
So there are three general patterns that we use for breast lifts. There's one that's just around the areola, and that's called a periareolar around the nipple. And that is really the least successful of all the techniques. It promises a lot. It promises just a simple scar around the areola, but it is not a reliable technique. And I've done it a few times in my career, but I don't recommend it. The second one is the lollipop, where you pretty much get a scar around the nipple and vertical. And we're going to talk about the traditional scar. The lollipop itself does move the areola to a higher position, but it doesn't shorten the breast. So you still have a long breast. And again, you can get away with it. There's less scarring, but I don't think the results match the traditional breast lift, which I'm going to show you in a second, those scars. And then one thing that has to be taken into consideration is a breast reduction versus the need for a lift with an implant. So in some cases, we're augmenting the size of the breast in addition to beautifying the shape of it. And then in the other case, we're reducing the size of the breast without an implant. And the second part of your question is the scarring, which is the most important thing that many women ask me. Oh my God, I want this, but I hate the scars.
Right.
So to me, the scarring, whether it's a breast lift or a tummy tuck, for instance, it's really, psychologically, you need to be prepared to have scars. It's an exchange. It's an exchange of form, shape, beauty for the scars. Now, if the surgery's performed well by a board certified plastic surgeon, you should have those scars be in a very private place. I always joke around that dogs and lovers should see that scar and no one else. But it's important to understand that each person scars differently. So some people, after a couple of years, you can barely see the scars. And some people, their scars are more visible. But I think psychologically it's important for the patients to understand that there will be scars involved. And there's no other way that we know yet of shrinking the size of a large breast without removing skin. So now let me go to the drawing board and show you some of these patterns.
Okay, that would be great.
All right, so the first one we're going to talk about is the periareolar lift. So essentially it's around the nipple. So we want to put the nipple here. So this technique involves cutting a big circle like that, perhaps making the areola a little bit smaller. But the challenge is moving this to here, and that the circumference out here is much bigger than the areola. And matching that doesn't really work well for me. There's some people perhaps in their hands that technique works, but essentially you end up with sort of a bunched up areola, and it's held together by a suture, and sometimes that suture breaks, and then you end up with a very large areola, same size as the original cut. So I don't prefer that technique. The second one is the lollipop. So the areola is here, we want to move it here. So we do a similar pattern, but it's only vertical. So the areola is moved into this position, and you end up with a breast with the areola in better position and a long scar. But it doesn't shorten the breast. The breast is, the nipple goes into a new position, but it still have a long breast. So if you really want to have a more perky look, I don't like the lollipop. If I'm going to do this, I want the perky breast. And that's where taking out the lower part really shortens that breast and makes it much more useful.
How long do the results of a breast lift typically last?
So breast lifts it's a very good question, because the most important thing about the breast lift is the nipple position. Once you put that nipple position in the right place, that should be for the rest of your life. Now, barring if you gain tremendous amount of weight, something like that, that position should stay relatively fixed. What can happen though, even with modest weight gain, weight loss, perhaps a pregnancy, you can get some stretching out of the rest of the breast tissue. And this is where you would go back in and tighten that tissue, and perhaps use that internal bra to again help hold the tissue up. But in general, the position of the nipple is, if you do it once and you do it right, that's forever. And the rest, you have a pattern of scarring already that you can use to tighten things up
I see.
over your lifetime.
Wow, very interesting. Let's jump into traditional breast reduction. Okay. For women considering breast reduction, what are the main benefits beyond aesthetics?
So the easiest answer to that question is quality of life. So women that have and suffer from having large breasts, they live with a burden. And this is real. And I've been doing this for a long time. So when you get to know your patients, which a doctor should know their patients, when you get to know the patient, you understand their suffering. And they suffer from severe back pain, strain, neck pain, and grooving. This is a tremendous burden, and it's a daily. This is something they suffer with daily. So the breast reduction becomes one of the most gratifying surgeries that I perform, because the relief is felt in the recovery room. Right after the surgery,
Wow.
the patients, they go, oh my God, it's gone. And it's something that these women, unless they're horizontal, they're feeling the weight literally on their lives, not just their bodies.
Yeah. Yeah, I have a couple of friends whose lives were miserable because of.
And there are many, again, factors that affect, there are genetic factors why women get their breasts grow larger, weight gain, weight loss, will change the breast. So on average, half of the breast is made of breast tissue and the other half is made of fat. So a lot of women, especially now, with large breasts, they're understanding, with the GLP-1s and losing weight, that this does help them significantly. But then some women that just have so much glandular tissue that it's just impossible, and you do need the surgery to feel better.
Yeah. What kind of scars should patients expect with traditional reduction?
So the full pattern. So essentially, we use the same pattern as for a breast lift. The only thing is that we take advantage of that situation to remove, while the breast is open, we remove a significant amount of the breast tissue. On average, 30% to sometimes even 50% of the breast of the volume of the breast can be reduced. Now, the risks of a breast reduction, as you're removing more of this breast tissue, when we reposition, and this is important, because a lot of people think we cut the nipple off and just move it.
Right.
The nipple always stays attached to the breast tissue. So there's blood supply and nerve supply. So if the surgery is done appropriately, most of the time, and there's always a risk of losing sensitivity because you're dealing with a lot of cutting in important areas. But if the surgery is done properly, the risk of losing sensitivity is very, very small. And if it's done properly, the other risk is blood supply. Because remember, as you're removing breast tissue, you have to leave enough to supply the nipple with nerve supply and blood supply. And those are the biggest risks of the operation. Really the viability of the nipple. So you're always fighting this battle of how much tissue do you remove versus how much you leave behind safely.
Yeah. Well, that sensitivity issue is a big one. I mean, I know it would be for me.
And that's important. And you have to, that's one of the things that I explain to my breast reduction patients, that it can be impacted. But sometimes you can have a decrease of sensitivity for a while, but many times it tends to come back.
It comes back?
It can come back.
Well, that's promising. Good. That's great. How is the recovery from a breast reduction different compared to a breast lift?
So if you're doing a breast lift without an implant, it's very similar to a breast reduction. Now, if you're adding an implant, now it's a little bit more traumatic because we're going under the muscle. And so now you have more of the muscular pain of an augmentation plus the breast lift. And the breast lift and the breast reduction, essentially the same recovery, the same discomfort after the surgery, which is usually not a lot since you're not cutting the muscle. Usually when we do surgery, what really hurts is when we cut the muscle. Mm-hmm. And that's really the difference between those two operations.
Now, let me ask you, I'm just curious about this. Let's say you have a patient that comes in for a breast reduction, but then all of a sudden, she's so used to having big breasts, and then she comes back and says, want a little bit more. Can you go in and do it?
Absolutely.
After that?
And this has happened to me sometimes, but I'm usually very careful as far as the counseling. And it's important to have these discussions with a patient because many women that have large breasts, that's been part of their personality throughout their lives.
Exactly.
And so when we're talking about, some women come in, they say, just take them off. And I have to sit there and remind them that having larger breasts help to shape their personality, that all of a sudden you go ahead and just taking them off might not be the best. It might be a knee-jerk reaction, but this is where the judgment of the surgeon has to come in and let's talk about reality, right? Because there's something like to take them off.
Right.
Not necessarily a good idea, because after the fact, some women might say, oh my God, my breast, I don't have any breasts left. So you take that into consideration. And if you do a great consultation, you should be in the same mindset as the patient. for that.
Well, that's why it's so important to see a board certified plastic surgeon that can educate you on not only the actual procedure, but your mental health and,
And I
what
think
happens.
interviewing, and you should meet with more than one. I think any type of surgery, you should have some sort of connection with your surgeon. And I think,
Absolutely.
and we've lost this a lot in modern medicine. I think we've gone into this sort of factory type style work.
I agree.
I think it's important, especially if you're having surgery, elective surgery, you should look around and interview different surgeons and make sure that you connect. You have to, surgery is not a perfect science, but you have to know that this person that's going to operate on you will be there for you before, during, and after the surgery.
Absolutely.
And I think that's critical. And people, and I tell them, do your homework, make sure they're board certified plastic surgeons first. And number two, make sure that you connect with them and that they're willing to give you the time and their energy and their care.
And unfortunately, some people do not do that. And just recently, we saw something happen here in Miami. Poor lady. But let's go into our next group of questions, which is implant removals. Okay. When implants are removed, what happens to the breast shape immediately after surgery?
So if you just remove the implant, you can have essentially a deflation. So if many times, and I've done it a few times where I've gotten away with it, or where I was able to maintain some sort of a harmony, a good looking breast, even after removing the implant. But in general, if there's been any type of a size of an implant that's been there, you're going to have to do some type of reduction of the tissue. So some type of a lift, not a reduction of the breast tissue itself. I actually use the remaining breast tissue to reconstruct the volume of the breast.
Oh.
So this technique that I've been working on is really repositioning, especially the sides of the breast. As the implant comes out, then you have this essentially a deflated breast. And so you do a breast lift technique, but only with skin. So all of the breast tissue remains, and I use that tissue to recreate the volume of a more youthful breast.
Okay. Oh, I didn't even know you could do that.
So that term is, so the big term and being thrown around, it's explantation. That is the vogue word of the day. And it's important for a lot of women for different reasons. Some women have had breast implants for many years since they're younger. And like I said, sometimes they were bigger and they're just ready to get rid of them. And other reasons right now, there are popular breast implant illness is being talked about a lot. And you really have to take this into consideration when evaluating your patients and say, okay, what are the goals? What are we doing? And so we could be on the same page for getting a great result.
Well, thank you for touching on that. That was going to be one of the questions is the hype that's going around with the breast.
The illness, breast implant. So breast implant illness is a multi-symptom situation with many patients that are being attributed to having breast implants. And it's, let's say it's controversial. Whether this is a true illness, whether there are other things going on. There are millions of women with breast implants in the country, in the world. And the symptoms of breast implant illness are very similar to other symptoms that have been thrown around when you couldn't find anything really wrong with someone. Like fibromyalgia is another one that, people used to say, okay, you have fibromyalgia because you have aches and pains and this and tired and this and that. And there are a multitude of symptoms and they just don't know what to blame it on. So it's very easy to say, oh my God, you have breast implants and all your problems are coming from having breast implants. Now, is there some truth to it? I can't really comment on that because honestly, I've read one side, I've read the other side.
Okay.
And I know women that swear that they've had their implants removed and they feel better. But I also know enough about psychology that if you truly believe that's the cause of your problems, you're going to feel better. So to me, it's more important just to understand the needs of the patients, what each patient wants, and to counsel them and say, okay, can we do it safely? And can we get it done so it makes them happy and I can achieve it in a safe manner?
Thank you for that. That was a great explanation of everything that you hear and you don't know what to believe, honestly. How do you determine whether a patient needs a breast lift after implant removal?
So, well, that one's more, like I said, it's just, it's easy to picture a full breast and then you take out the fullness. So if you realize that is going to be just too much skin left behind after having an implant in, then the lift there becomes more of a, where I mentioned before is a nipple position situation. Then this becomes just a skin removal because now there's too much skin compared to the breast tissue that's left behind. So we have to then use that pattern that we talked about
Right.
to remove skin and make the breast tighter and more.
What are the recovery expectations for implant removal alone versus removal with a lift?
So removal alone is relatively simple. I mean, there you take that implant out. We leave a drain in sometimes for a few days, and that's it. Many times, depending if the patient's had like scarring around the implant, capsular contracture, then we could take out that capsule. But essentially, that's definitely the difference there is are the scars. That where you just take out the implant, you could do it through the same incision that it was placed through.
Right.
And then, but many women wouldn't be happy with just empty breasts. It's just not very attractive. And that's when you need to do a lift.
I know that breast surgery is such a huge topic, and we're not going to cover it all in one shot. But what do you recommend for women who feel anxious about breast surgery? And what are the specific steps or conversations that can help ease their concern before?
So let's to different age groups, right? So you have the younger girls that perhaps they want bigger breasts, and they're coming in and they're my job, and sometimes they come in with their parents. And I think the job of the surgeon is to really evaluate why you're doing this operation, and to really truly be a guide through this process of sizing. Like some girls, they hear from their friends, oh no, I want this. Oh no, I want that. And there's a lot of peer pressure, and especially now with social media. Oh no, so and so got this, so and so got that. And at the end of the day, I think my job is, and using my 25 years of experience, and if we're talking about breast surgery, it's actually 30 years when you count my training.
Of course.
And to say, okay, this is reality. This is what you can expect, and this is what will work for you. Now, and I do that, and I still come back, and there's a lot of pushback from their friends saying, well, my friend got this, and my friend got that. So one of the biggest challenges for me is to really spend the time with the patient so they truly understand what it is that they're doing for themselves. Because unless you have a twin, no one's breasts are identical.
Right.
And their friend's going to go, well, I got this and I got that. And Kylie Jenner got this. And it's my job to make sure that people know that it's you that are having surgery. And it's you that needs to make these choices.
Of course. Thank you so much for your time today. This has been fabulous. I'm sure that we are going to need another podcast to cover more. But I sincerely thank you from the bottom of my heart, and our viewers, thank you. We have so many positive responses from the transparency and the honesty that you present your podcasts to Mari.Trilogy. Thank you so much, Dr. Soler.
You're quite welcome. Happy to be here.
So ladies, don't forget to subscribe to Mari.Trilogy on YouTube. We will be bringing Dr. Soler Baillo back, and the next podcast will be on liposuction and body contouring. So keep in touch. Stay tuned.